so that even those who missed it or those who want to hear it again, they can access the WBAP website. So thanks to Kalpana ma'am, who has initiated this year. So I would request on behalf of WBAP to say a welcome address to all of the delegates. Professor Kalpana Datta, who's the present president of WBAP. Unmute Korena. Please unmute yourself.
Yeah. Thank you, Dr. Atanu. And a very good evening to everyone, and welcome you all, these August faculties, to this digital platform for having a e-webinar series. We are having lots of academic activities like Shando Pathshala, a workshop on different small topics, and another is the e-library series. So we have a Thalassemia. So today we have a very prominent and August faculties, and they are all experts in their fields. They'll be sharing their experiences and knowledge with us about the thalassemia and hemoglobinopathies. We know the commonest hemoglobinopathy now currently is the thalassemia, and this year's theme was aware, share, and care. So unless we are aware about the thalassemia, how can I share the knowledge and how can I care the patient? So without wasting much time, I'll open the session for discussion, and I'll request our scientific chairperson, Dr. Shapun Kumar Roy, please introduce the moderator. Where is the moderator? I can't see.
No, I am the moderator today.
Okay, you today, Dr. Kostal is not joining. Okay. So Dr. Shapun, say a few words and start the topic, I think, discussion.
Shapun, please.
Good evening and welcome you all. Today's webinar e-library series is on the thalassemia care to cure. So our chairperson are none other than Dr. Jogesh Parikh, Dr. Vishwajit Mishra, and Dr. D.K. Singh. And today coordinator is Dr. Atanu Bhadra, and moderator is Dr. Purna Kurkure ma'am. And the panelists are Dr. Janani Shankar, Dr. Nehal Patni, Dr. Ruchira Mishra, Dr. Shantanu Dev, and Dr. Kodas Das. So I'll request moderator Dr. Purna Kurkure.
Thank you. Thank you, Shapun. So
later, start you. Just introduce Purna ma'am. Yes.
I would request first the chairperson to say a few words. Thank you, Dr. D.K. Singh, for joining. He has a issue in a family occasion, but anyway, he has managed to join. Sir, we will start with your words, please.
Good evening to everyone. And but just I want to highlight one thing in this webinar, that there should be a guideline, clear guideline for especially for the private practitioners, because they are seeing a lot of cases, and what should be the cutoff line to refer the patient, and how it should be clarified, and how it should be rather differentiated from other types of anemias which may mimic like thalassemia. So this must be focused on the private practitioners, because most of the pediatricians are private practitioners, and the teaching faculty and the at teaching facilities, hospital also, there is not much development in this bone marrow transplant or stem cell transplant or other chelators. These are the things which are very difficult to start the treatment. So I request all the dignitaries to come out with some clear-cut guideline when a private practitioner should refer to tertiary care hospital, especially designed for the thalassemia care. Thank you. Thank you, Atanu, and thank you for giving me this chance to participate in your seminar. Okay, thank you.
Thank you. I think the panel will take up your suggestion, and probably CIP also will take it up later in the future. So we have the thalassemia problem is very rampant, very severe in some parts of Eastern region. And I request Dr. Vishwajit, who is our Vice President of the East, to say a few words before we hand over to Jogesh Bhai. Yeah.
Good evening, everyone. First of all, let me congratulate West Bengal Academy of Pediatrics for coming up with this e-library series, Thalassemia Care to Cure. And today we have really a good panelist team with Janani Madam leading the team, along with Dr. Nehal, Dr. Vichira, and Dr. Santanu and Dr. Palas from Odisha. I think IAP is coming up with something on thalassemia and other immunoglobulopathies very soon, and it will be a guideline for the common pediatrician as well as what to do, what not to do, when to refer. And we had a meeting, I think, regarding this as an OB regarding some guidelines for common treatment from common diseases and its treatment. And I wish this academic extravaganza today all the best. Thank you so much.
Thank you, Vishwajit. And now we hand over to Yogesh Bhai to introduce Dr. Purna. And for introducing Dr. Yogesh Bhai, it's very easy. He doesn't need any introduction. And his contribution to different parts of IAP and different parts of the country is well known, starting from NRP to ECD. His reach is really wide. So, Yogesh Bhai, I would request you to say a few words and introduce Dr. Hand it over to Dr. Purna, ma'am.
Thank you, Dr. Ratnubhai, and all the panelists and the moderator. First of all, congratulations to West Bengal Academy of Pediatrics, led by Dr. Kalpana Madam and Dr. Indrajit Chaudhary, and the scientific chairperson, my dear friend, Dr. Tapan Rai, and today's coordinator, Dr. Kaushal Nayak. And we welcome moderator, Dr. Kalpana Madam, panelist, Dr. Janni Madam, Nehal Patel Madam, Dr. Ruchira Madam, Dr. Shantanu Dey, and Dr. Palash Das. Today, on the 23rd May 2023, happy to announce the inauguration of the regional hub of the training of the beta thalassemia at the CTC PHO and BMC Center at Mumbai, Borivali. And today our president is there to inaugurate, and this is the IAP's attempt to strengthen the thalassemia care system throughout the country with the partnership with the IPO India. And in the this pilot project, we are having a similar center in the Kolkata and the Bhopal. So we must thank Dr. Sandeep Balla from the IPO, as well as Dr. Mamta Manglani Madam and Dr. Smita Radhakrishnan Madam for their initiative and for involving the IAP. IAP is partnering with the BMC in the Mumbai, Kolkata Municipal Council and NHM Bhopal towards the attempt towards the zero thalassemia. So let us work together and march towards the zero thalassemia. This is our theme of the thalassemia currently we celebrate. So thank you very much for the inviting me, and thank you for all the let us welcome and start the program.
So we hand over the stage to Dr. Purna Kurkure. She had been she is a well-known hematologist and a hemato-oncologist rather, and she is a very special interest in thalassemia. So ma'am again doesn't need an introduction, has been a part of OB, the office bearers of CIP for the last 4 years. And please welcome ma'am. Thank you for taking your time. We had been disturbing you when you were outside the country, and it speaks for her dedication that she had continued and still is doing this program today. Over to Purna ma'am.
Atanu, let me add here, Dr. Purna Kurkar Madam is working with the Cancer Foundation, and recently we have a meeting on the 13th of this month with the Foxy IAP and the Cancer Foundation with some USA officials. So Madam is also working for the cancer part. Thank you very much.
Thank you.
So, can you hear me?
You're audible, ma'am. Just unmute yourself. Mute ho gaya phir.
You are again muted, madam.
Ma'am, you are not audible. You are muted. What I'm Yes.
Yeah.
Yes, now okay.
Requesting is okay.
Again muted, madam.
Again muted, ma'am. I think there is a problem with her connection. She is getting our signals late.
Using
Yeah, now it's clear.
two devices, which now is it clear?
This is clear.
No,
Yes.
I am getting the echo effect. 1 second. There is some, I don't know what
If it is
is the
two
problem.
devices, Purna ma'am, if it is from two devices close by, then it would be an echo.
No, but if I
But ma'am, you are using your own main device.
मैडम लैपटॉप से ही बात करो.
No, it's muted again.
no, there are two devices.
Okay.
So you please unmute only the mobile and keep me muted for another device. The one with the P, you keep unmute.
It would be difficult
That
from
is my
the
mobile.
backup team, ma'am. It better you do it yourself because otherwise everyone will be muted.
P is now muted, madam.
No, P.
Now
keep
it's
P,
cleared. Now it's cleared.
Keep P unmuted. And
Okay.
the other one, my picture, Dr. Puna Kurkure has muted.
Okay, then can Mr. Somnath do that?
Somnath, can you make ma'am has
Yes.
joined from two devices? Now can you unmute this device?
You please raise hand in second device so that I
No, in the second device only P is coming.
P.
Yeah.
Where is P? In panel. No, there is
Yes.
no panel.
Yes, there is one P. Faculty member. It is coming as faculty member.
No, there is no P. Ma'am, can you please raise the
नीचे
hand?
देखून faculty member लिखा है. हाँ,
Okay,
faculty member.
okay. Faculty member, there is one faculty member.
Yes, that one you unmute.
Okay. Unmuted. It's unmuted. Faculty member unmuted.
Can you hear me?
Yes,
Yes.
ma'am, now clear.
And now it will be clear because I have kept my laptop on mute. Okay, sorry for this technical glitch. And good evening and welcome to this very interesting webinar on thalassemia care to cure. During this month of May, which is celebrated starting 8th May as an International Thalassemia Day or a World Thalassemia Day. And this year, the theme of the day was education and awareness, which can lead to care and cure. So it is very apt to have this webinar during this month to raise the awareness and care of the children with thalassemia. I have a very esteemed, can I share my screen, please? Can you allow me to share my screen?
Somnath, please allow ma'am to share the screen.
Already allowed.
Okay.
Allowed? Okay. Thank you. Can you see my screen?
Yes.
Okay. So I have an esteemed faculty panel to discuss various aspects of thalassemia with the theme of care to cure. And as you can say, Dr. Shantanu Dev stands out very prominently, being the only male panelist. Dr. Shantanu Dev, Dr. Janani Shankar, Dr. Ruchira, Dr. Nehal Patel, and Dr. Palash Das. And I'll just quickly give you the gist of Dr. Shantanu Dev. He is a senior consultant and HOD Pediatrics and Neonatology, Nazareth Hospital, Shillong, Meghalaya. and he has been EB member and also interested in infectious disease. So he has held position in the infectious diseases and is a past president, treasurer, editor of IAP Meghalaya. And he has a very brilliant academic background. And Dr. Janani Shankar doesn't need much introduction. She is a current EB member of Central IAP and the medical director KKCTH Hospital, also chairperson of the Tamil Nadu Infectious Disease Chapter. And her interests are hematology, rheumatology, and infectious diseases, along with the emergency medicine. Dr. Ruchira Mishra is my colleague at SRCC Children's Hospital managed by Narayana Health at Mumbai. She is a senior consultant in pediatric hematology, oncology, and bone marrow transplant. And her area of interest is pediatric hematology, oncology, and bone marrow transplant, with a special interest in the bone marrow transplant for thalassemics and relapsed malignancy. Dr. Nehal Patel, she is a professor and head Department of Pediatrics, GMER's Medical College, Sola, Ahmedabad, Gujarat. And she has been also currently the executive EB member of the Central IAP. She's the president of Women's Wing of Ahmedabad Academy of Pediatrics, Gujarat in 21 and 22. And she's a very active young person in IAP. Her special interest is pediatric intensive care, neonatology, hematology, and adolescent care. And Dr. Palash Das is an associate professor, Department of Pediatrics, Kalinga Institute of Medical Sciences, Kalinga Institute of University, Bhubaneswar. And her interest is also in hematology, oncology. So with this esteemed panel, we start our webinar now. And as we all know, the normal and abnormal hematopoiesis of thalassemia due to the genetic defect where the red blood cells are malformed and they get destroyed earlier, giving rise to anemia, which further leads to the expansion of puts the marrow, makes marrow more hyperactive. And this vicious cycles goes on with the production of abnormal cells which get destroyed earlier and hyperactive bone marrow. So these are the two main problems of thalassemia. And as you can see here, we fall into the hot zone, that is a thalassemia belt. With every year, approximately 100,000 children with thalassemia major are born world over, of which 10,000 are born in India. And it is estimated that at a given point in time, we have around 65 to 67,000 beta thalassemia patients in India, with around 9 to 10,000 cases being added every year. So you can see the cumulative burden which will go on at this rate. The carrier rate for beta thalassemia gene varies very widely from region to region, but it is from 1 to 3% in southern India and 3 to 15% in northern India. And communities at risk which are defined are Sindhis and Punjabis from northern India, Bhanushalis, Kachis, Lohanas from Gujarat, Mahas, Neo-Buddhist, Kolis and Agris from Maharashtra, and Gaudas and Lingayat from Karnataka. So these are well defined. And also from the eastern region, there is a belt which contributes to large number of thalassemia. And we are all aware of the inheritance. I don't have to again and again repeat this. This has been taught very well at the basic pediatric training, that you have a trait and two traits, two partners having the beta thalassemia trait. When they come together, then you have a 20%, 25% chance of child without any trait, means the outcome of such pregnancy is 50% chance of a child with a trait, which is a minor, beta thalassemia minor, and 25% chance of a child with beta thalassemia major. So there are three possibilities. Affected child and 2 traits, 50% chance, or a normal, totally normal child. So, and if you have a thalassemia trait with a normal parent, then the probability is that only you will have a 50% chance of a thalassemia trait child, and others are normal. So with this little background, let us start with our discussion. And I'll ask first question to Dr. Nehal Patel. How do I know if my child has a thalassemia and what are the symptoms and signs? Dr. Nehal, your slides I have incorporated. So can I just run through them?
Yeah, sure. So it's okay, ma'am. Any slides. The main thing is the common thing for a pediatrician to know. And majority of the pediatricians, they know that if the child which is of thalassemia major, which is generally going to be a transfusion dependent child, if they come, they will present with severe anemia and maybe in the failure. So we receive a child with the hemoglobin of only 2 or 3, and then with these cardiac failure signs also. But if they are transfused and then they are coming to some other pediatricians, then they may have typical thalassemic phase with the expanded marrow space. There may be some jaundice, there are some cholelithiasis or splenomegaly, and there are some bone changes, fractures, and they are stunted. So growth failure is also there. But it's not always that all the majors are only affected. Sometimes some minor also, they have the transfusion dependent thalassemia, and these children also, they present with the severe anemia. The other minor, they don't present and they stay a little anemic, mild anemic, but not with the severe anemia. So these are the pictures just for the better clarification.
And as you can see, with the expanded, ill-managed or ill-transfused children with thalassemia, we'll have an expansion of the bone marrow because of the hyperactive marrow, and their flat bones will get distorted and they look so alike that it is like a USP of thalassemic who are not very well managed transfusion-wise. So you can see 2 children with the similar kind of faces due to the expanded marrow space. Now, Dr. Janani Shankar, can you tell us the investigation which will be required to confirm the diagnosis?
Yeah. So when you have a child with a hemoglobin that is less than 7 on 2 occasions, or you have a child with a hemoglobin a little more than 7 with features that Nehal mentioned now, you should suspect thalassemia. So the confirmatory test, or you have to do a peripheral blood smear which shows bizarre RBC morphology, and your indices, MCV, MCHC, everything is low, and an RDW is wide. And the confirmatory test is HbA1c, where you have a high hemoglobin F. So that's how you diagnose.
Okay. So basically it is the anemia suspected, which is not looking like, it is a microcytic anemia, but
Yes.
with the Metzer index, which is indicative that you must investigate further, and you investigate before you transfuse for the first time with high levels of fetal hemoglobin, and then you go for the further studies which are required, because you may have a combination, you may have a only the, and it is very important to know the subtypes of even beta thalassemia if possible. So, Dr. Ruchira, question to you is, what is a thalassemia trait, thalassemia minor? And the common question is, if I have a thalassemia trait, does this mean that I have a disease, or what is the implication on the life of a person with thalassemia trait?
So, ma'am, thank you for inviting me to this webinar or this panel discussion. Whenever we talk about thalassemia trait, and we often get a lot of referrals because somebody is being picked up as a thalassemia trait when their HbA2 level is high. And they're very worried as to how it will impact their life per se. So the first reassurance that we give to families is that in most cases, a thalassemia trait does not actually impact your life at all. Most of these patients may have a mild anemia. They may have features of fatigue, like Dr. Nehal mentioned. They do have features that may have mild anemia or associated with iron deficiency anemia, but they generally do not need blood transfusions throughout their life. They may need some iron supplements or may need an occasional transfusion whenever they're in a high output state. So that is why we say that all thalassemic traits actually don't get picked up unless there is a reason to suspect that their family members or somebody else is also affected. What should we do if you are thalassemia minor or when you have a thalassemia trait? Both are the same conditions. What it really impacts is who you marry and what will happen to your offspring if you were to marry another thalassemia trait. Like you showed in your cartoon, we saw that if two thalassemia traits marry, then we know that they have a 25% chance that their child may be affected and may have thalassemia major, which may have a lot of morbidity and may have an early mortality as well. However, if you marry a normal person, then your children may be either normal or they may actually be thalassemia minors like you are or the parent is, and they also have the same propensity to have a normal life. So if you are detected to be a thal minor, we generally recommend that you find out that your partner is also has the electrophoresis done and should be a normal person is there. So that is what is most important in our patients. As hematologists, we often tell in our awareness camps that आपको जन्मपत्री मिलाने की कोई जरूरत नहीं है, पर आपको अपनी HP electrophoresis करके वो electrophoresis report मिलाने की जरूरत है. So two thal traits should actually not marry each other.
So this is just whatever Dr. Ruchira just mentioned about the trait or a minor thalassemia and a major thalassemia, and how we can pick them up if, and trait needs to be monitored properly before marriage, that they accidentally don't marry another thalassemia trait person. So now to Dr. Santanu Dev, the question is, if my child has been diagnosed with thalassemia major, but he does not require blood transfusion every month, is it really a thalassemia? This is a question many people. The thalassemia is equated with a transfusion and transfusion dependency. So is it true that all thalassemics require a transfusion and they are transfusion dependent?
Yes, madam. So, since the child has already been diagnosed as thalassemia major, it probably means that the child is homozygous. And luckily, this child has escaped the clinical manifestations of thalassemia major. So they fall somewhere between trait and thalassemia major, and they are called thalassemia intermedia or the non-transfusion dependent thalassemics, NTDT. So they will have clinical features which are much milder compared to the thalassemia major. So their clinical features will start after the age of 2 years. Their hemoglobin will be maintained somewhere between 7 to 10 grams per deciliter. Their complications will start much later, at a much later age. And even though they may have iron overload, symptoms of iron overload or signs and symptoms due to iron overload, these will all occur much later because they are not really dependent on transfusions. So they luckily will be, even though they have thalassemia, they will luckily be a subset of patients who are non-transfusion dependent thalassemics.
So this is a good thing, and this is just a recapitulation that various thalassemias, how they behave hemoglobin wise and
Yes.
clinical presentation wise. Like beta thalassemia major will always present in a most severe form with less than 5 gram of hemoglobin. Hemoglobin F up to 100% in many situations. And beta thalassemia intermedia will have the hemoglobin level of 7 to 10. And hemoglobin F, fetal hemoglobin, can range from 10 to 50% with a HbA2 of more than 4%. So how they and hemoglobin E and beta thal, that combination also many a times doesn't give rise to a severe symptoms like a thalassemia major. So we have to remember that not all thal, if they are in combination, they protect each other, like hemoglobin E and thal. And hemoglobin H also we have to remember, which can vary very widely. So all thals are not, thalassemics are not transfusion dependent. And this thing is not moving. 1 second, huh? My slide sharing is not moving. Pause.
Click inside the slide, ma'am, it will move.
Huh?
If you click inside the slide, it will move.
Thank you. So this is the whole spectrum from transfusion seldom required to occasional transfusion to intermittent transfusions to regular lifelong transfusions. So this is the whole spectrum of non-transfusion dependent thalassemia and transfusion dependent thalassemia. Dr. Palash, what PRBC transfusion remains the mainstay of care soon after diagnosis? And what are the guidelines for transfusion? What is the best transfused child with thalassemia? And how do you monitor these children for a best transfusion practices?
So thank you, madam, for giving me an opportunity to be a part of this panel discussion. So once we have diagnosed thalassemia, the only way of giving up for keeping the child in a good state of health is to give a PRBC transfusion, and unless we don't go for curative therapy. So the most important thing to remember is that it should be packed RBC transfusion. PRBC transfusion, there is no role of any whole blood or any other transfusion. Number 2 is it should be started at least when there are two values of at least less than 7 gram per deciliter 2 weeks apart. And whose blood it should be? It should not be a family donor, because whenever we utilize a family donor, there is an increased risk of alumination and there is an increased risk of GVHDs. So it should not be a family donor, first degree family donor, and it should not be from professional donors. It should ideally be a voluntary donors. After that, what is the pre-transfusion hemoglobin? The pre-transfusion hemoglobin should always be between 9 to 10.5 gram per deciliter. And please remember, before starting on PRBC transfusion, please remember to do the diagnosis of thalassemia. Because once a blood transfusion is given, after that doing an HPLC becomes very difficult for the next 2 to 3 months. Then what is the amount? The amount, of course, depends on what is the hematocrit of the transfused blood. But most of the blood banks maintain it around 50%. So the dose of blood should be around 15 to 20 ml per kg. And it should be given, again, various guidelines say various time, but it should be from the time of issue from the blood bank, it should be tried to be finished within 4 hours. And the most important thing is we should not try to achieve a very high transfusion, post-transfusion levels, except unless there are some other complications like extramedullary hematopoiesis. Otherwise, hemoglobin post-transfusion is maintained for 13 to 15 approximately. Another thing is, before we start on any transfusions, what is ideal is to do an extended blood group typing. So while we do ABO typing is done almost routinely everywhere, these children will require a lot of blood transfusions. They are very, very prone to alloimmunization. So ideally, all the children should have an extended blood group typing of C, D, E, and K. And ideally, a blood which is matched for these minor blood groups should be given.
Dr. Palash, do you have this how these children, when they are on a repeated blood transfusions, they are more prone to get the transfusion transmitted infections like HBS, HBE, this HIV and other thing. So other thing is also NET testing. What are your
Yes.
views on NET testing for such children when they are going to get the repeated transfusions?
So ideally, as ma'am you correctly said, there is a high chance of transfusion transmitted infections, out of which we are very much worried for HIV, HBx, HCV, and for that, ideally, all the blood should be at least tested by NAT, which is now almost being followed by law by most of the, has to be followed by most of the transfusion centers, and so that it reduces the window period. And another thing is that questionnaire based selecting proper donors, selecting a proper blood, which is ideally less than 2 weeks old, which is a fresh blood, should be selected.
Okay. So, Dr. Janani, what are the differences between packed red blood cells, leukodepleted PRBCs, leukoreduced PRBCs, and irradiated PRBCs when they are required, and how do you go about? Do you transfuse everyone with a very specialized PRBCs, packed red blood, or you begin somewhere and then at some point in time you introduced all other devices like leukodepletion?
Yes, ma'am. So once we start the thalassemia child on transfusion, initially we don't do it, but over a period of time they develop minor hemolytic transfusion reactions. So non-hemolytic transfusion reactions. So to prevent that, maybe after 6 months of transfusion, after 6 to 8 transfusions, we start using the leukodepleted RBC, which is done at the time of collection itself, storage level itself, or bedside it is done using leukocyte filters. So the other thing is irradiated PRBC, again using, this is to reduce the GVHD post-transplant and post-transfusion. So irradiated using gamma radiation, they are irradiated, and leukodepletion is either done at the time of collection or at the time of transfusion bedside using leukocyte filters.
So which is a preferred mode? Is it you collect that is preferred, or bedside leukoreduction is a preferred mode?
I think collection site reduction is better, ma'am. I mean, I do not know. I may be wrong. You have to correct me. I am under the impression that that is better.
Okay. So, Dr. Nehal Patel, what is meant by phenotype matched donors? What is its significance and how to plan a dedicated donor program? Because these are the issues which come up when child is on a continued transfusions, regular transfusions. So when all this is required, phenotype matched donors.
Yes, ma'am. The phenotype matched donors, actually it is required. As we know, the International Society of Blood Transfusion, they gave us 38 blood group system. Majority of us, we are knowing only the AB, RH system, otherwise nothing else. But there is an extended RBC predicted phenotypes, specifically 12 major clinically significant blood groups, and there are many others. So some of these antigens, they are highly immunogenic, and then they risk the carry of alloimmunization in the recipients of the blood. The most clinically significant allo antibodies are RH, KL, KIT, and Duffy. So all these antigens needs to be screened, and they are screened by high throughput genomic testing for the blood groups, which allow the large scale antigen typing and then assessment for the donor pool compatibility. for the chronic transfusion dependent population. This is the specific aim to decrease the RBC alloimmunization, and that's why the phenotype matched donors are required.
Okay, so when do you start doing this extended phenotype matching? Do you do it from upfront, or do you do it in a clinical setting where there are some reactions which happen or some indicators are there, or intermittently to just track what is happening? What is the clinical practice generally?
Yes, actually in our center, we are not able to do this phenotype matching because ours is a new center. But majority of the well-developed centers, ideally is always to do it from the start. But majority of the well-developed centers, they try to do the patients if they see some of the patients if they are at the high risk. So, ma'am, you may be having a better idea for this, but at our center, we are not doing. And the main thing is this dedicated donor program we are doing is only for the neonates, that we keep a matched donor for that neonate to decrease the alloimmunization, and all the blood products are separated, the RBC, PRBC, FFP, and they are kept for that neonate only, so that the repeated donor transfusions and the donor matching is avoided. But for thalassemic patients, we are still not able to do. So at your center, if you have experience, ma'am.
Dr. Ruchira, you have some comments to make?
Ma'am, I agree with Dr. Dr. Nehal that it should be ideally done right from the beginning, but it's very, very difficult, especially since the requirements are so huge. Calling a donor every kind of getting them ready and getting the PRBC aliquots ready every 15 days or every 3 weeks is actually impossible to do. So it's very, very difficult to actually follow. There are very few centers in India who actually manage to follow this kind of a policy. Normally, when we find that there is some alloimmunization happening, that's the time that we start looking for dedicated donors to kind of prevent it from getting aggravated again. But it's a huge challenge. So yes, ideally it should be done, but I don't think that practically a lot of us are able to do it. In our center, we are not being able to do it right now. We only try and do it for patients who already shown some signs of alloimmunization.
Yes, so ma'am, as Dr. Ruchira said, that for this initiative was taken up by Turkey, and in Turkey they developed a program for the dedicated donor program, and for that they gone for a slogan that those who are dedicating this thalassemic child, the donors who are dedicated, they are named as the blood mothers and the blood fathers, and so that leads to a connection between them, and so they are also motivated to give the blood to these thalassemic patients.
Okay, so there is it's an organized effort to identify such dedicated donor and incentivize or motivate them by their recognition as a blood mothers and father. That is very interesting. So next is Dr. Ruchira. How do we screen for iron overload? We all know that the destruction of RBCs leads to even the transfused RBCs, they get destroyed early, and that leads to release of iron and cause a iron overload, which is the main cause of various organ dysfunctions. So how do we screen for iron overload, and what are the tests, and how frequently should they be done?
Ma'am, one of the reasons why we are so worried about iron overload is that this is one of the major causes of mortality or death in our children, because cardiac iron overload often leads to cardiac desaturation and decompensations, and that leads to cardiac failure and death. And similarly, liver iron overload also leads to liver problems, and also in the pancreas and the pituitary. So the iron overload is one of the major reasons why our children develop problems as their age increases. we also know that just about 1 to 2 milligrams of iron would actually be absorbed from our body if we were to go through without blood transfusions, and a similar amount gets excreted, so the body maintains a balance. But if we're giving blood to a patient, then almost 200 milligrams of iron keeps getting added every time there is a blood transfusion happening. So if you just take a rough estimate of about 25 units of blood being given, almost 5 grams of iron is being added, which is quite a lot for the human body to be able to adjust. How do we measure this? There are a few tests that can be used. The normal ways of measuring it is by measuring your serum ferritin, which is the easiest to do and therefore is the most commonly used, although serum ferritin is actually an acute phase reaction. So it can go up or it can become high if the child is sick for any other reason also. But in most thalassemics, it's quite a reliable source of measuring iron overload by a simple blood test. So you get the serum ferritin measured whenever you're doing your CBC. The recommendation is that you measure it once in 3 months because your iron chelation will depend on that and the doses can get adjusted based on that. The other ways that you could measure iron would also be non-invasive. You could ask for what is called a T2 star MRI. So this is by doing MRI studies, you estimate the levels of iron in the liver, in the pancreas, in the pituitary, and in the heart. And therefore, based on that, you can decide whether you need to change your chelation therapy or not. A T2 star MRI is generally recommended after about 5 years of age, and we recommend it once maybe in a couple of years to be done because otherwise it becomes a big financial burden for our patients. The gold standard for measuring iron overload is actually a liver biopsy and measuring the liver iron. But because it's an invasive test, we rarely follow that. We use ferritin and the T2 star MRI to be able to measure that. But if somebody asks the ideal method, then that would be to measure the liver iron and see what it is. You could also measure the urinary iron excretion, and if that is more than 20 milligrams per day, that indicates that there is iron overload. But this is a test that's rarely used right now.
Okay, thank you. So, Dr. Shantanu, now that we are at the iron overload and we need to chelate these children regularly, which is the best chelator, oral or IV? And indications for this, oral versus IV? And what is olepticine? Benefits over the standard oral chelator.
Madam, because once chelation is started, it will be needed nearly lifelong till blood transfusions are being given to the child. So we need to think of so many issues while selecting the chelator. The best or the ideal chelator would be one which is oral, which does not cause discomfort to the child, which is efficient, which has minimum side effects, whose dosing is low, that means probably once a day, etc. And at present, the oral chelator, Deferasirox, is probably the most preferred one. So it has once daily dosing. It comes as dispersible tablets. The standard one comes as dispersible tablets. It has to be consumed before meals, but it has some side effects like GI side effects, nausea, vomiting, etc. And it can also have transaminitis and may be responsible for deranging the renal function tests. So these are some of the problems that are there with Deferasirox, but usually this is the one which is used widely. Our literature has more evidence on the injectable chelator, that is deferoxamine, and it has been used for a long time. But the problem is that it has to be given as infusion over, say, 12 hours, which is subcutaneous or IV infusions, and these actually decrease the compliance and cause a lot of side effects, in the sense that the child is not comfortable while taking the IV chelator. So Oleptis is a new generation Deferasirox, which is film coated, and because it is film coated, the GI side effects of Oleptis is less. It can also be given as single daily dosing. The amount of dosage is actually less for Oleptis, and also the compliance with Oleptis would probably be better because it can be had after meals also. These are the benefits of Oleptis over the oral chelators, but cost-wise it is higher than Deferasirox.
Okay. So, Dr. Palash, now can you tell us about a new drug in the market approved for adult use and whether it can stop the requirement for blood transfusion? And this drug, whether it will be taken lifelong, what is the situation and how this new drug acts?
So there is this new drug, luspatercept, which is now marketed in the name of Rosusta or Rebuzil, and it has been approved for adults. For pediatric, the trial is ongoing from 2021. So we do not have any pediatric data on it. It works basically in thalassemia. The main pathogenesis is in the ineffective erythropoiesis, and this drug works on the TGF beta superfamily, and it reduces the ineffective erythropoiesis. Now the question is whether it will stop the requirement of blood transfusion. So it has been studied in adults. There were 2 trials, and what they found is in non-transfusion dependent thalassemias, it has reduced the blood transfusion, maintained hemoglobin levels of more than 15 in as high as 80%. But in thalassemia major, the endpoint was only a reduction by around 30% of the blood requirement in 12 weeks. So yes, it can reduce the requirement of blood transfusion in thalassemia major. In non-transfusion dependent, it might stop the requirement. And yes, it has to be given every 21 days. The route is subcutaneous. The dose ranges from 1 to 1.75 milligram per kg. And the most limiting factor will be definitely the cost of this. It comes in 2 strengths, 25 and 75 milligram. So the cost is still a major
What is the cost
problem.
of that, Dr. Palash?
25 milligram will be approximately 30,000 and the other one will be around 80,000. I have not yet used it, so I think, ma'am, you can shed more light on it.
No, we are also not using it. It is just, it is a cost. Cost is the biggest constraint for everyone because
trials are going on.
And in pediatrics, the trials are still on. It is not,
Yeah.
it is approved for
Not
adults.
approved. Not
Yes.
approved.
Okay, so if you don't use this costly drug, we have this age-old thalidomide and hydroxyurea, and there are trials and attempts to use that. How does that work, Dr. Nehal Patel?
Yes, ma'am. So hydroxyurea, actually, it's a age old that we use hydroxyurea now since many years, even in the sickle cell anemia, in sick health, and also now in the thalassemia. So it has its own proved role. And both these drugs, they generally have been used as an HbF inducers. The thalidomide is also an immune modulator and it causes suppression of the nuclear factor Kb production in inflammatory cytokines such as the tumor necrosis factor, and which potentially increases HbF. So by this, they decrease the need for transfusion, and by that they improve the hemoglobin levels also. So the children also improve clinically and hematological parameters. The other studies are on the use of combination of hydroxyurea and thalidomide. In these studies, they have started with those who are already on hydroxyurea, they have added thalidomide. Or in our center, we have even new recruited the children for this combination only. And now we are comparing that either only hydroxyurea is working better, the combination works better, or the thalidomide work better. The results are yet to be done statistics on it. But what we find is thalidomide and hydroxyurea, when used in combination in the children who are in younger age, then the complication rates are much higher, like alopecia. Then there are some blood counts which are decreasing, neutropenia. But if they are used in the adolescents, or I say more than 7 years of the child, then they are generally not having much complication and the results are really good. The thalidomide dose is 2 to 5, but the recommended therapy, if you are using with hydroxyurea, start with the low dose, that is 2 to 3 milligram per kg. You can go to the intermediate of 3 to 4, and then there is high dose. If the child is tolerating, you can go up to the 5 milligram per kg per kg per day.
Okay, so this is another possibility of supporting the transfusion by decreasing the transfusion needs. So, Dr. Palash, we all know that these children, they'll end up in towards the end of the first decade by 8 to 10 years with a significant splenomegaly. Even the splenomegaly or the size of the spleen is a direct indicator of how well the child is transfused or not. So if you have, what is the role of splenectomy if you have a large spleen in a thalassemic, and when should one advocate a splenectomy?
So what it has been seen is with following of proper guidelines of maintaining a pre-transfusion levels of 9 to 10.5, nowadays the splenectomy rates have fallen a lot. Like previously, probably 3-4 decades back, as high as 50% children required splenectomy, but now in centers where the transfusion guidelines have been followed properly, the rates have fallen down. Splenectomy may be advised if the blood requirement is more than 220 to 270 ml per kg per year, and that differs from centers to center. If there is a huge spleen which is causing symptoms such as early satiety, respiratory distress, huge abdomen, something like the picture we saw in the first slide. So probably in those cases, again, splenectomy may be advised. And if there is a risk that there might be a splenic rupture because the spleen has come outside the rib cage. It's a huge spleen which is covering the abdomen. There is a risk of splenic rupture. In those cases, a splenectomy may be advised. However, it goes without saying that spleen is an essential organ. Removing a spleen is a major decision. There is not only risk of opportunistic post-splenectomy infections. So before doing a splenectomy, definitely all children should get vaccination against the capsulated organisms, mainly the Haemophilus influenzae, pneumococcal and meningococcal, at least 4 to 6 weeks. If there is, of course, if there is features of hypersplenism, it's another indication for splenectomy. And in these children, there is very high risk of thrombosis and pulmonary hypertension, and these should be kept in mind before and after going for a splenectomy.
Okay. So we all have seen while caring for these children how a hematologist or even a primary pediatrician has to take care of the transfusion, then the iron overload, monitoring of the iron overload, and the other means to decrease the transfusion requirements. But despite all this, it's quite complicated. And as Dr. Ruchira had told earlier, that each transfusion adds iron, which causes various organ dysfunctions. So, Dr. Ruchira, again, you can highlight as to which specialties should a thalassemia clinic have.
Ma'am, thalassemics should ideally be taken care by a doctor or a healthcare professional who is interested in thalassemia care and is interested in holistic care for these. So all those pediatricians who are there, if you are setting up blood transfusion facilities for your children, please have a very active interest in looking after these children, because it's not just blood transfusions they need long-term care for these children, and they will need repeated monitoring and stuff. So a pediatrician with a very good interest or a clinical interest in thalassemia is probably the first person I'd like to put on my list of what a thalassemia clinic should have. A hematologist who can look after and guide their care better, but the actual care would be given by the pediatrician itself. He will have to look after their vaccinations, he will have to look after their growth, their repeated blood tests and all that. We talked about iron overload, so having a hepatologist come in at timed intervals would also help these children, so they can monitor. And since a lot of them may get blood transfusion related infections, so their hepatitis C, if they get hepatitis C or if they get hepatitis B, can be looked after by the hepatologist. as these children grow older, they will start developing endocrine problems. So the endocrinologist needs to be on board as well. So the thalassemia clinic should have an endocrinologist coming in and seeing these patients as well. A few of these children will become parents themselves, and when they marry, they will need some fertility counseling. So having a fertility counselor or having a gynecologist with a good interest in fertility would also help, but this would be in long-term care for these patients. They would need mental health support, so having a good counselor or a psychologist, and may sometimes even need care for a psychiatrist, but at least having a counselor on board within that thalassemia clinic would be really important. I cannot stress the importance of having a cardiologist and having annual cardiac tests done, because these children definitely get cardiac overload as well. So it becomes everybody's work involved in the care of these children that actually takes care. So it's not one person, it's the whole village that will need to look after them.
And that is how we have a lot of support groups to look after the psychological and others part of the child, like thalassemic societies help the children to have the necessary drugs, transfusion services, guidance for that. But we also have a lot of thalassemia support groups where they meet and they share their experiences to keep them motivated to go on. Dr. Janani, what are your recommendations for monitoring the bone strength of children with thalassemia? We all know that bone marrow gets expanded. There is also endocrine overlay. So how we monitor the bone strength and what do we do as an intervention?
Usually recommend DEXA scan, ma'am, to look at the Z score and treat them accordingly. Ideal age that we start doing the DEXA scan is from 8 to 10 years of age, and it should be done on a yearly basis after that. And we should supplement them with calcium and make sure that they don't go in for fractures and severe osteoporosis. So a regular DEXA scan after 8 or 10 years of age is the recommendation.
Okay. And what are the endocrinological problems that are generally faced by thalassemics? Dr. Shantanu?
Yes, ma'am. Even though mortality is mainly because of cardiac toxicity or the effect of iron overload on the cardiac system, it is the endocrine system which faces the brunt. There is widespread ramification of the problems of the endocrinal system due to iron overload. So the things that are involved in the endocrine system could be short stature, could be hypogonadism, there could be hypoparathyroidism, there could be hypothyroidism, then there could be diabetes mellitus or impaired glucose tolerance. So many endocrine organs are basically involved because of iron overload. And therefore, we need to think about how to monitor these children for effects of iron overload on the endocrine system. We should start monitoring the child as soon as the blood transfusion start by monitoring the height of the children. Then the rest of the endocrine problems usually they manifest after after a number of years has elapsed. So thyroid, parathyroid, glucose tolerance, diabetes, sexual development, all these should be monitored after the age of 10 years. For sexual development, every 6 monthly from 10 years of age. For the rest, at least annually, one should monitor them after 10 years of age.
Okay. So this is very, very important for a growing child as to how we take care of the endocrine system for their normal growth and development.
Yes, ma'am.
So, Dr. Janani, what are the current curative options available to children with thalassemia? The title of this webinar is From Care to Cure. So far, we have talked about the care, how to diagnose early, how to manage the transfusions, how to manage the transfusion-related problems. And these are all caring for a child with thalassemia. How now we move to the next portion, that is the cure. So what are the current curative options?
Yes, ma'am. So, stem cell transplant is the ultimate curative option, and it should be offered to transfusion-dependent thalassemics as early as possible. And of course, donor, we discussed a lot in length about that. And the ideal would be matched sibling donor or a matched related donor. If you don't get that, you can go for a matched and related donor, or a haploidentical donor also can be used. And if the newer options are gene therapy, where you have the replacing the defective gene with a normal gene, and autologous stem cells are also modified in vitro with a vector bearing the normal gene. So that is one, and gene editing is also there. Two methods have been used so far: the CRISPR,
CRISPR,
and CRISPR and Cas9, or the zinc finger nuclease. So the BCL11A gene is reactivated by editing the promoter region. So, and this leads to a higher HbF production. And by doing this, transfusion independence may be achieved. So, of course, I think Palas already discussed about the loose recept, which in which still trials are going on in children. And of course, thalassemia, thalidomide and hydroxyurea, or the others, which at least reduce the requirement for transfusions till such time the child is getting a donor for ideal donor for the transfusion.
So you are right. The current most curative option is a stem cell transplantation till we get some really simple and other methodology of editing our genetic aberrations and offer the gene therapy. So Dr. Ruchira, what are the steps in bone marrow transplant? What is the success rate for haploidentical transplant? Dr. Janani said that you can either do the ideal thing is to do the matched sibling donor. But as we all know, the probability of getting the sibling donor is only 25%. So remaining 75% of the patients will have to look for the alternative donors. So today we have not a very vibrant, but very good stem cell transplant donor registry program in the country, which also has a tie-up with many international stem cell donor registers, and we can find the matched but unrelated donors. And then you have a half match or a haploidentical transplant, which comes straight from the parents. So without searching anywhere, with the ease of getting the donor is very good. So what is the success rate for such a haploidentical transplant, and is it a standard of care? And as we all know, transplants are a highly financially challenging intervention. So what are the help and how much does it cost? And how do we get the help? Dr. Ruchir.
Thanks, ma'am, for giving me an opportunity to answer this question. I am basically a transplanter, so I feel that every child who's been diagnosed with thalassemia should get an opportunity to have a bone marrow transplant. And with the current advances in technology, we do not have a problem in getting donors for transplant. So like you mentioned, the best results are with matched sibling donor transplants, which means that we find HLA matched sibling. So when you're describing the steps of a bone marrow transplant, the first step would be to do an HLA typing for the patient as well as all the family members. Now, a lot of people question us whether it has an impact on the donor. It doesn't have any impact on the donor. And even if the donor is a thalassemia carrier, it's good enough because they generally don't need transfusions. So we will convert a thalassemia major into a thalassemia minor, or maybe a normal person as well, but at least we will take away that requirement for blood transfusions from this patient. So the first step of any bone marrow transplant program is to get an HLA typing done, and that should be done at the earliest because your HLA doesn't change throughout your life. So when you start getting repeated transfusions, we use a buccal swab, or we can also do it with blood samples, and we do this HLA typing for the patient and then look for donors. Once you've identified the donor, then the remaining steps go. We check the second step would be to check that the patient is fit for a transplant, which will involve some blood tests and will involve some X-rays, some CT for looking at the chest for infections, monitoring their hormonal status and all that, and then taking up for transplant. We give them a conditioning regimen, or we give them chemotherapy to destroy their marrow and make space for the new cells, and then we give the cells from the donor like a blood transfusion. So unlike other transplant programs where there is surgery involved, in a bone marrow transplant, there is no surgery involved. It's a physician's transplant. The only surgery is for putting a central venous catheter in these patients. So once the transfusion is given, then once the infusion of the cells is given, we then wait for the cells to start growing, which takes about 10 to 14 days. And this is the most crucial time for any transplanter, because that's when the child is completely immunosuppressed, does not have any immunity per se, and is very prone to infections. But once the cells start growing, then we plan for a discharge. We monitor for complications of transplant, the biggest of which is either infections or graft versus host disease. And the third that we look for is relapse, rejection. Rejection could be either primary or it could be secondary. In most cases, we say that if you've crossed 1 year post-transplant, then we expect that the graft will stay and that the transplant is successful. Now, when we talked about the different types of transplant and the success rates, when we talk about matched sibling donor transplants, where we're looking at a brother or a sister being matched, or even a family member being fully matched, and generally right now we're looking at, in a family member, brother or sister, we look for an 8x8 or a 6x6 match is also good enough. But if other family members are there, we look for a 10x10 match for these patients in their HLA matching. Success rates with matched sibling donors are at least about 80 to 90%. The earlier we do the transplant, the higher the success rate. So if children are transplanted before 5 years or 8 years of age, then our success rates are between 85 to 90%. However, if they're irregularly chelated, or if they're older children and they have more of iron overload, then the success rate drops. The second kind of transplant which we offer is a mud donor transplant, or a matched unrelated donor transplant. Like you mentioned, that there are registries now in India as well as abroad, which offer you donors who are voluntarily donating their bone marrow or their stem cells for children who need them. And thalassemia is one indication for that. In India, we have at least 3 registries who are actively working for them, but 2 are main. One is Datri, which operates from Chennai, but has a nationwide presence. And it has about 5 lakh donors that are available. In India, that number is still low. For the kind of population we have, 5 lakhs is a very small number. So we don't find a lot of donors still for a lot of our thalassemics. The other registry is DKMS that operates out of Bangalore. They have a smaller number of donors, but they will also look for it both in India and internationally. And if there is a donor available, we can always try and approach that donor to donate the cells. The third kind of transplant, which you all, Dr. Janani also mentioned, was a haploidentical transplant. With the advances in technology, now we feel that in India especially, this is the transplant that is going to kind of keep coming up, and we'll be doing more and more of haploidentical transplants. The reason being that parents are always willing to do anything for their children. So even if it means donating their stem cells or donating their bone marrow, they will willingly do that. We have to make sure that both the parent and the patient and the donor are fit to donate, and that involves some blood tests and investigations like I mentioned. There is a trend to do a pre-transplant chemotherapy, or PTIS as it is called, where we give some chemotherapy and medications to the patient for at least 1.5, 2 months, sometimes even 6 months before the transplant, to make sure that their erythroid hyperplasia becomes a little quiescent, and then we take up for transplant. Haploidentical transplants are generally done in by 2 methods. One of them is called a T cell deplete transplant, and the other is called a T cell replete transplant. In a T cell deplete transplant, we take away the T cells because we know that these T cells are the ones that cause majority of the complications. This is slightly more expensive than the other variation, where is a T cell replete transplant, where we just infuse the cells like we would have done for a matched sibling or a matched unrelated donor. The complications of a T cell replete transplant are more, though the initial cost of the transplant is slightly less in this case. So the most of the people who are doing haploidentical transplants for non-malignant conditions like thalassemia advocate that we should be looking at a T cell deplete platform to be doing it for the patients. As you mentioned, the cost is one prohibitive factor, and that's what kind of prevents people from opting for this kind of therapy as the curative option for their children. But with the proactive nature and the force that has been used to create awareness for thalassemia and also to look for help for these patients, a lot of organizations are coming up to help these children. There is Coal India Foundation, which is one of the biggest benefactors for children with thalassemia. They've actually promised a lump sum amount for all matched sibling donor transplants for children with thalassemia. And therefore, you can, up to the age of 12 years, that is a caveat for them, that up to the age of 12 years, they will support them. So they give a huge sum, that is 10 lakhs, which is almost about 80% of the cost of the transplant itself for these patients. So there are centers in India who have been recognized for this. But there are also other NGOs like Tata Trust that gives out a lot of money, and individual donors also who are willing to help these patients out. Also, the social platforms that exist, the social sites that exist like Facebook and Instagram and all these areas have a lot of crowdfunding opportunities as well, where certain organizations are actually helping the parents out and looking for crowdfunding for these patients. So if a parent decides that they want to get a transplant for a child, it will probably take them between 3 to 6 months, but the funds will be collected for these patients. So if anyone wants to do a transplant, there is we always have a donor available, because we know that it can be a matched sibling, it could be a mud, or if nothing else, then a haploidentical transplant. And then there are also these multiple avenues by which we can actually get money to get the transplant done for these patients. But they will require long-term care. So the pediatricians also need to be prepared to look after these children once the children come back to you. So I can, as a transplanter, do the transplant and look after them for the first 3 to 4 months, but then the remaining time period they're with the primary physician, and they need to be sensitized about the transplant program and what complications to expect, and look after these children once they're back with them.
Okay, so it is very encouraging to say that now we have a curative option, though complex and costly, complex and costly, but there is an option. And we as a pediatricians have to remember that giving transfusions, however well they are managed and along with relation, is ultimately not the answer. And as the child gets older and older, this curative option becomes more difficult and difficult. In terms of outcome is poorer. So if we have to, as a pediatrician, what we can do first is to sensitize the parents that transfusion is not the cure. It is only a symptomatic management. And ultimate cure will come only from a stem cell transplant. Otherwise, they become complacent, and particularly so when in our government gazette, transfusion services are given free to thalassemics. They think that this is the ultimate, and they forget about the curative attempts. So this has to be avoided, and they have to be made aware of these curative attempts. And the good part of the story is, though transplant is very expensive thing, it is a planned transplant, so you can collect the funds over a period of time, get going. So earlier you start, better you are. That is the important message I would like to give. Now, Dr. Palash, what is the current role of gene therapy in the management of thalassemia major? Have we reached there, and what are the different types of gene therapy that you are aware of?
So, since thalassemia is a genetic disease, it just makes sense that genetic therapy would come up. And as people have gone more into the pathogenesis of thalassemia, multiple gene therapies have been tried and tested. Out of which, probably two I would like to mention. So number one is Zentelgo, which was by the Briobliss, which has now got FDA clearance, where basically it's a ex vivo type of gene therapy, where the cells are taken, this hematopoietic stem cell from the patient are taken. They are manipulated in the lab by a lentivirus. That lentivirus gives the corrective gene. So, and then it is transfused back. It's almost like an autologous transplant. The patient is then given a myeloablative chemotherapy, and then the modified stem cells of the patient, which has been modified in the lab, are given. So this is one which has got FDA clearance and might be coming up in future, might be even available to us, but presently the cost is very, very prohibitive. The other one was CRISPR, as Janani ma'am mentioned. So CRISPR is basically now we don't have FDA clearance as of yet for that. But for CRISPR technology is thought to be a bit cheaper, where basically the target is to increase the HbF production and lead to increased HbF. So yes, gene therapy is there in definitely in pipeline, but it might be some time before it becomes available to us.
Thank you, Dr. Palaj. So now we have talked about the care, probable way of cure. But let us aim to have a zero thalassemia situations, as it has been done in many parts of the world. Like we are all aware of such efforts in Greece and so on and so forth. So what is how can one prevent thalassemia? What should be our strategy and goal towards that? Zero thalassemia.
Yes.
Dr.
So,
Nehal.
So, ma'am, before some or few years, we were like, is the prevention possible, or is the zero thalassemia? But some of the countries, as you say, have done it. So we should also aim at zero thalassemia. Prevention is a multidisciplinary approach. So what is required is mainly the adequate knowledge about the thalassemia. And after the adequate knowledge is done, now you need to discourage the consanguineous marriages. If it is not possible, then at least do a premarital screening test. And by performing them, you can avoid the marriages between the thalassemics. Now, for this, we can even go for the genetic counseling and the antenatal diagnosis. The option of therapeutic abortion is still a debated thing in India, but our government guidelines are going to be there for this. The options of antenatal diagnosis, if we have the chorionic venous sampling at around 8 to 10 weeks of fetus with the fetal DNA. Then we have PCR analysis, and also the genetic analysis of the mutations which are going in the thalassemia, that is also available. Actually, it should be go for not only the family screening, but the extended family screening, so that the prevention can be done. If I talk about that in today morning only, when I was going through the newspaper of our local newspaper, there was an article on the Gujarat government has decided to go for the those couple who are going for marriage registration. They need to give a certificate of thalassemia. This was planned a few years before, but because of some problems, it was not there. Now they are again coming up. So this type of government initiations are also required. If the people are not coming willingly, then some of the force from the government will make them will, and then it will be in the habit. So yes, prevention is possible and the zero thalassemia is possible.
Thank you on that very optimistic note that we can all work towards a target of zero thalassemia. So in doing this, Dr. Shantanu, can you just tell something more about the antenatal diagnosis? What is pre-implantation genetic diagnosis and its role in thalassemia care? And which centers would have pre-implantation genetic facility? And what are the steps of this procedure? Are there any
Yes.
side effects?
Yeah, PGD or PIGD, as it is known, is used in a lot of chromosomal and genetic disorders for diagnosis. It is basically in IVF pregnancies, the embryo before implantation. A part of the embryo is biopsied and the genetic testing for mutations is done to find out whether that embryo has the defective genes for thalassemia or for any other chromosomal disorder. So that is the basic principle by which it is done. And as you can understand that it can only be done for IVF pregnancies. So the centers which now undertake genetic diagnosis by means of doing biopsy are actually regulated under the PCPNDT Act, and they are known as genetic clinics. So they are stringently, actually, they are accredited after a lot of stringent regulations, and they are given permission where genetic diagnosis can be done in the biopsied embryos. And this biopsy is done in the blastomere stage or the 8-cell stage, where a portion of the embryo can be taken up and then it is subjected to the genetic diagnosis. So while doing the biopsy of the embryo, there are some perceived risks which may be minuscule, but most of the side effects of PGD is related to the IVF process as a whole. So it is postulated that there could be loss of the embryo, there could be death of the embryo, the live, the biopsied embryo may not lead to a live birth, etc. But these numbers are very low, and it needs highly technical and highly skilled personnel to do this method of PGD. So the side effects also I have said, and these are the steps actually in the blastomeres, in the pre-implantation, the embryo, when it becomes 8-cell, probably that is the time when the blastomeres are biopsied and the genetic diagnosis is made. Specifically, I would not know of which centers, but it cannot be done in the friendly neighborhood IVF centers, of course, but in bigger centers.
Okay. So friends, we have covered the whole spectrum of thalassemia care, complications, cure, and how to prevent or eradicate, which will lead to eradicating thalassemia. So the question is that as a society, we say that we don't have a thalassemia, but then how a society, as a member of society, you can help. The most important thing which as a citizen we can do is be a blood donor and register to be a stem cell donor, because it has been described by Dr. Ruchira that only 5 lakhs stem cell registered donors, means 5 lakh people have registered in the registry. So we have such a huge population that if we register as a stem cell donor, we can save more lives, and we have a power to save lives. So this is the last message I will give before we close this webinar. And I hand over the platform to our organizers and the chairpersons to give their final remarks. Thank you all.
Thank you. Purnam ma'am, can we take a few questions in the chat box?
Okay.
One is that what is the exact cutoff period of doing HPLC after blood transfusion?
Dr. Janani, can you please highlight? Dr. Janani, is she on board?
She was there.
She left.
No, I think she's not there.
Okay.
Yeah.
So what is after transfusion? What is the cutoff? Anybody can say.
Any duration of time where you can give the HPLC, you can do the HPLC.
The problem is that once you have a thalassemia major, your blood requirement is such that you never reach that period of safe time, safe cutoff to do the HPLC. Dr. Shantanu, can you say some few tips on that? practical aspect. If you have transfused because child has come in failure, how much time should be allowed before you can have a meaningful HPLC result?
Maybe after 90 days of the
2 to 3
transfusion.
months, 3 months at least.
But you don't get that opportunity of
Yes,
3 months.
yes, we do
That
not
is
get
a catch-22 situation, because those who are thalassemia major and transfusion dependent, they generally
we never
require,
get,
they don't go for 3 months that
Yes.
way. So before the next, I would put it that way, that before the next transfusion, as much as you
Okay.
can, like in the earlier period, when you have a child who comes in a failure and you are forced to give the Paxil transfusion to bring out the child from that failure, the next transfusion, before the next transfusion, generally in the early part. But if you go on with few more transfusions, then the requirement will go up, and then you will not get that period. Ideally, it should be 90 days, but you don't get those 90 days to do the HPLC.
I mean, these patients, if you find that you're not getting the correct HPLC, yet you have a clinical diagnosis of thalassemia, it's worthwhile to test the parents. If they have thalassemia trait, both of them, then you can say that the child has thalassemia major. Otherwise, you're going for the mutational analysis for these patients.
Yeah. So the diagnosis would be pretty obvious at that time if this child is coming with in that situation. Okay, so I think I thanks panelists for the wonderful session. I would request Kalpana ma'am to say the vote of thanks. Kalpana di, please.
Yes. So it's a wonderful session. Thank you all the panelists and the moderator, madam. You have not left any points unturned from the clinical features, investigations, management, complications, follow-up, monitoring, and the curative therapy with the prevention part. So it is in total in a 1 hour time. I was a bit surprised. How can you cover such a huge chapter in a 1 hour? Very nicely covered. And I must thank all the panelists. They have shared their own experiences. I must thank the chairpersons, the moderator, Dr. Atanu, and the scientific chairperson, Dr. Sapun Roy, and all the attendees. They're still there in the night of 10:35. So I must congratulate all the attendees, and thanks from my side, from the WAP side, for having me over here in such a late night with the scientific sessions. Thank you all, and we'll meet you again in some other webinar. And thank you all the, Shomnath also, who has created this platform, Zoom meeting, and others also. Thank you.
Yeah, and
I think
Kalpana di, I think
Purna ma'am for giving us the questions so that we could prepare the answers. Thank you, ma'am.
And we'd like to thank Professor Kripasindhu Chatterjee. He could not join today. There has been a severe storm in his area, and all connections.
In Kolkata also we had a storm. I was stuck in the hospital. And what about the Dr. Kostam Nayak? He didn't join.
Yeah, both of them could not join because of the severe.
They have a disruption in the electricity and connectivity.
Yes.
So both of them have not been able to join. But I'm glad that we could discuss the whole spectrum of thalassemia care to cure. And I'm very thankful to all my panelists for really answering all the questions which were, and I especially thank Dr. Ruchira to help me at my workplace to formulate together and brainstorm over this. So thanks all.
Okay. Thank you.
Thank you. And